e-learning from Chennai, India. I'm Dr. Prem Sekar. I'm an interventional pediatric cardiologist at Kauvery Hospital, and this is coming to you from Kauvery Hospital. Quiz is on Ebsteins anomaly today. It's a fascinating topic, and hopefully it's structured in such a way that by the end of the quiz we would have covered all the important aspects of Ebstein's anomaly, and also give you a fair idea of the management across the age group. So we'll go on to the first slide. Start off with a fairly easy one. What's happening here? Yeah, there we go. So identify this doctor. Take your time. Identify the doctor. There's a query from Bharat Kumar Sharma saying, is it Dr. Ebstein? I expected that. Any other answers? Okay, give you one more clue. Okay, with the second, any guesses as to who the doctor is? How many people are on the chat now? I want some answers, guys. Who do you think this doctor is? I've got one reply, Dr. Fallow. Okay, so let's get on with it. This is Dr. William Raskin. So the reason I put up this slide was basically the initial knee-jerk responses is it Dr. Ebstein's. Now I just wanted you to think hard about the rest of the slides that are coming through, and no knee-jerk responses. Think hard and answer diligently. Okay, you're all medical doctors, so it's not fastest fingers first here. Think hard and answer intelligently. A good doctor doesn't do things fast; he just does things very diligently. Okay. So with that perspective, let's move on to the slides now. Okay, so this is a 4-chamber view of a baby, and what is the diagnosis? I just want the diagnosis, fairly easy. Just look at it carefully and give me a diagnosis. Yeah, so tricuspid regurgitation with a ASD, that's good. So this is a mimic of Ebstein's anomaly, and in your practice, many a times you will come across a typical scenario like this, where the patient will present to you with a diagnosis of Ebstein's anomaly. This is not Ebstein's anomaly. Reason being that the tricuspid valve is dysplastic here. It's thickened. This is congenital tricuspid valve dysplasia, characterized by thickening of the valve leaflets. There may be incomplete separation of the valve leaflets from the ventricular wall, but not totally adherent like in typical Ebsteins. There may be tricuspid regurgitation because of failure of coaptation, and there may be focal agenesis of the valvular tissue and a very shortened chordae. So this is tricuspid valve dysplasia. And the typical feature that sets it apart from Ebstein's is what? The absence of septal leaflet displacement. Okay, so yeah, that's right. So Dikta has answered correctly. So there is the typical absence of the insertion of the tricuspid valve leaflet is at the correct place. There's no displacement like in Ebstein's. So it's important to recognize this and not send them to surgery as an Ebstein's anomaly. Right, so this is case scenario 1. Look at the fetal echocardiography. This is an Ebstein's anomaly which was detected at 24 weeks gestation, and what you're seeing is a follow-up fetal echo at 34 weeks. List the features you would look for when you are doing an echocardiography in a fetal Ebstein's anomaly. What are the features you would look for? Can you list them for me? I just want you to list, not elaborate, just list the conditions you would look for. Take your time, just list the conditions you would look for the diagnosis. You know it is an Ebstein's anomaly. What are the things you would look for to make a diagnosis? Yes. Septal displacement, right? Tricuspid regurgitation, pulmonary atresia. I would say more like the flow pattern across the pulmonary valve, associated lesions, LV non-compaction, good. What else? A few more important things you would need to look for when you are doing a echocardiography in a fetus with Ebstein's anomaly. Anything else come to mind? Eye drops, yeah. Okay, so let's go ahead and mitral valve abnormalities. Not much, not really. Okay, so degree of displacement of the tricuspid valve matters, that was mentioned. So that is something you would look at. The tricuspid valve regurgitation is an important feature you would look at. The cardiothoracic ratio, again, that has a bearing. That is something you would look at, and that is calculated the cardiac dimensions compared to the complete thoracic dimensions, and the blood flow pattern across the pulmonary valve, which way it is flowing, whether it's flowing at all. So that is again important. Very important, foramen oval size and flow pattern. So this is something which all of you, when you are doing fetal echocardiography, especially in a fetus with Ebstein's anomaly, you need to focus on that. RV to LV ratio is something you look at. Presence or absence of hydrops, that was mentioned, and the cardiovascular profile score. So these are the things which you should not miss when you're doing a fetal echocardiography in a fetus with Ebsteins anomaly. Okay, so next, list the bad prognosticators. Which of these would tell you that the fetus is not going to make it, or fetus has a very bad prognosis? Hydrops, small RB, dilated RB. Okay. What are the really important bad prognosticators that will tell you severe TR? What would you look for when you see the TR, the tricuspid regurgitation? What kind of information can you glean from that? You said severe TR, but how does it tell you what features of the tricuspid regurgitation will help you prognosticate? Low profile score, dilated RA. No, I was just asking a specific question here. The tricuspid regurgitation, somebody mentioned severe tricuspid regurgitation. What feature of the tricuspid regurgitation will help you prognosticate? Would the tricuspid regurg velocity? Yes. A low pressure TR. That's good. Sudipta Bhattacharya has replied. Low pressure TR, how does it help in the prognostication? Somebody said severe TR. What does a low pressure TR imply? That's correct. Low pressure TR implies what? It implies a very poor right ventricular function. Okay, so that is again a indicator of a bad prognosis. Okay, so that is tricuspid velocity, TR velocity, CT ratio. If it is very high, and any other factors which are indicators of bad prognosis in a fetus with Ebstein's anomaly. I'm specifically looking for two very important parameters you would look for. Smaller LV, yes. That's what we mentioned, LV to RV ratio. Okay. I'm looking for two specific important parameters which are very bad harbingers of fetal mortality in fetus with post score, no. Okay, let's go on and look at the list. A degree of tricuspid valve displacement more than 2.5, so that was one of the answers. A low TR velocity less than 2.3 meters per second. This again implies low TR gradient and low TR velocity implies a very poorly contracting right ventricle or a very diminutive right ventricle, which is not a good sign. A high CT ratio more than 0.55. Very important. This is one of the most important one. Reversal of blood flow across the pulmonary valve at the first echocardiogram. So you see reversal of blood flow across the pulmonary valve. That's a bad harbinger of fetal mortality. And the next important point is the relative foramen ovale and atrial septal length ratio, which if you measure it to be below 0.36 at the last echocardiogram, that is an indicator that the foramen ovale is becoming restrictive. That's again not a good sign. The length of the foramen ovale to the length of the total atrial septum. If it is less than 0.36, that has been shown to be a very sensitive indicator of a bad prognosis in fetal Ebsteins. The ratio of RV to LV more than 2, so RV size more than double the size of the LV. And why does that happen? Because of the RV dilatation and compression into the LV. Okay, hydrops, yes. Presence of RVOTO is again a bad prognosticator, and a low cardiovascular profile score. So somebody had mentioned that a low cardiovascular profile score less than 7. So which brings us to the question, what is a cardiovascular profile score used for? What is cardiovascular profile score? UE Doppler, UA Doppler. Okay, so cardiovascular profile score, ductus venosus velocity. So it's an ultrasound examination where you look at basically 5 criteria and assess the the cardiac performance to quantify cardiac failure in fetuses. So you look at the presence of fluid, hydrops, or ascites or pericardial or pleural effusion. You look at the heart size, and you look at the cardiac function, normal mitral valve and tricuspid valve, biphasic diastolic filling, and the shortening fractions of LV and RV, arterial umbilical Doppler, and the venous Doppler. So if you look at these 5 criteria, and if they're all normal, you can get a maximum of 10 points, which indicates a normal cardiovascular profile score for the fetus. And as you go further down to the right, your cardiovascular profile score gets less and less. And if you have a cardiovascular profile score less than 7, that is a bad prognosticator indicating severe cardiac failure in the fetus. So if you do a venous Doppler of the umbilical vein and you find it throbbing, that's a bad sign. If you do an arterial umbilical Doppler and you find the end diastolic velocity low, that's again a bad sign. So cardiovascular profile score is something which you look at the cardiac performance of the fetus by ultrasound. So one finding in this case will make you advise elective cesarean section as against a normal vaginal delivery. One finding. What one finding will make you advise elective cesarean section as against normal vaginal delivery? Okay, answer is not forthcoming, so that will be eye drops. So in the above case, how does the presence, eye drops and flow reversal, yeah, that's good. So in the above case, how does the presence or absence of pulmonary regurgitation affect your immediate postnatal management? Say we'll take the scenario where there is no pulmonary regurg. What would that imply and how would it affect your management? Anatomical pulmonary atresia. Yeah, so that's an important thing. So you have to keep the ductus patent. Okay, so if you find severe pulmonary regurgitation, how would that affect your management? Functional pulmonary atresia will improve after pulmonary vascular, yeah, PVR comes down. If you find severe pulmonary regurgitation, how would that affect your immediate postnatal management? You're finding severe pulmonary regurgitation along with severe TR, as you can see here. Maintain ductus open is one of the answers. When there is severe pulmonary regurgitation, would you want to maintain the duct open? What would that lead to? Circular shunt, yeah. So that's not a very good idea to keep the ductus open. We'll come to that in a bit. So case scenario 2, neonate with severe Ebsteins anomaly and no RV outflow tract obstruction. What are the chest X-ray findings? One of the answers is a box-shaped heart. What is the cardiomegaly predominantly due to? RV. Yeah, RA dilatation, atrialized RV. Okay, mainly due to RA. And what else can you see from this X-ray? Any other findings? Yeah, pulmonary oligemia, good. Concave MPA segment is not a finding. Pulmonary oligemia, cardiomegaly, and a keen eye would have detected that this baby is indeed intubated and there's a right tube, so probably a very sick baby. Okay. So this is the blood gas. You do a blood gas and you find a pH of 7.1, PO2 62, PCO2 34, base excess of -15. Explain that. Look at the blood gas carefully. I want you to analyze that and tell me what the underlying issue is. Low cardiac output, good. Mixed metabolic and respiratory acidosis. Low cardiac output state and sick baby. So there is, yeah, so there is severe acidosis and hypoxia. How do you explain that? Severe Ebsteins anomaly, no RV outflow tract obstruction, a neonate with severe hypoxia and acidosis. Severe TR, no forward flow through pulmonary valve is one of the answers. Now, okay, so what else? How do you explain the desaturation? Right to left shunt across the PFO is the right answer. So you have right to left shunt across the PFO, and what would that do to the circulation? Why the acidosis? The low cardiac output. What is the reason for the low cardiac output? Yeah, why? Why the reason for the hypoperfusion and hypoxia? PDA open, then circular shunt, less forward flow. Yeah, so that is right. How would you prognosticate in this? You've done an echocardiogram, you've seen severe Ebstein's anomaly, you see a ductus open, you see reversal of flow across the pulmonary valve, and you see right to left shunt across the PFO. How would you prognosticate? High go score. Okay. What would be the management in this neonate? Poor prognosis is correct. How would you manage this neonate? Hyperoxygenate, low PCO2, pulmonary vasodilator. Good. So along the same lines, name the circulation. Good. Circular shunt. What is the criteria that would define a circular shunt? What is the one criteria that would make a shunt qualify as a circulatory shunt? Yes, so blood passes from one chamber of the heart and passes to another, comes back to the same chamber without passing through the pulmonary vascular bed, bypassing the pulmonary vascular bed. So that is the criteria for defining a circular shunt. Apart from Ebsteins with severe TR and the PFO and pulmonary regurgitation, what other conditions could exhibit circular shunting? Good. Yeah. So Sudipta has replied correctly. Pulmonary atresia with intact IVS with PDA, post-pulmonary valvotomy when the PDA is kept open. And you can also have the same thing with VSD and severe PS and the PFO. And very rarely there is a report of one case report in the annals of pediatric cardiology where a where a tunnel has been described from the pulmonary artery to the right atrium, causing a circular shunt. So that's a very rare condition. So what are the hemodynamic effects of circular shunting on the circulation? What does it do? Hypoperfusion. How does it cause hypoperfusion? Yeah, but how does it cause the low cardiac output is what I'm asking. How does it cause the low cardiac output? More runoff into PDA. So basically, yes, you are talking about systemic steal. The systemic steal effect is what contributes to the low cardiac output. And my next question is, can circular shunt happen in the fetal heart with Ebstein's anomaly? Can circular shunt occur in the fetal heart? Amitosh Singh has said no. Any other responses? PDA shunting right to left, so no. Any other responses? See, circular shunting is a condition where in Ebsteins anomaly, the severe tricuspid regurgitation draws the blood into the right ventricle across a competent, across a patent pulmonary valve. And when the ductus is open and the PFO is open, you can have circular shunting in the fetus in an Ebstein's anomaly with severe tricuspid valve regurgitation. So it can happen, but it does not cause a systemic steal because the pulmonary vascular resistance is elevated, so you don't have runoff into the pulmonary vascular bed. However, the right to left interatrial shunt can overload the left ventricle and can cause left ventricular dilatation and failure. So it does not cause a systemic steal like in the postnatal circulation, but circular shunt can still happen in the fetal circulation when the tricuspid regurgitation is severe. Good. So now we are coming to a very important question. Is there a role for prostaglandin infusion in a baby with circular shunt? Good. Answer from Mahendra Singh Parihar is right. There is no role for prostaglandin infusion because it will worsen the tricuspid regurgitation. It will, if there is functional pulmonary atresia is because of a increased afterload distal to the pulmonary valve. And if you have a patent ductus arteriosus in that setting, the patency of the ductus and the higher pressure in the distal pulmonary valve will impede antegrade flow across the pulmonary valve. And in the absence of functional pulmonary atresia, if you have severe pulmonary regurgitation, again, keeping the ductus open will only worsen, will drop more blood into the right ventricle and worsen the tricuspid regurgitation, increase the right to left shunt and cause worsening of the hemodynamics. So the role for prostaglandin when you have circulatory shunt is not a good idea. When would you, in what condition would you have to use prostaglandin in a baby with Ebstein's anomaly and severe TR? Whether severe RVOTO, yeah? And okay, so circular shunt, baby neonate with circular shunt, what is the management? I think that was answered earlier as well. Somebody said pulmonary vasodilators. Anything else? PDA closure, yes. So medical management would involve um, encouraging closure of the patent ductus arteriosus and reducing the pulmonary afterload to increase forward flow across the pulmonary valve with the help of pulmonary vasodilators, preferably inhaled nitric oxide. If these medical management fails and the baby continues to deteriorate, what would be your line of management? Surgery. Well, this is a sick baby with a circular shunt, and as you have seen, severely hypoxic and acidotic, low cardiac output. So, what kind of surgery would you go for? What immediate surgical intervention would help this baby? You need to interrupt the circular shunt. At which point would you interrupt the circular shunt surgically? Close the PDA is, we are dealing with a condition where there is a diminutive RV, may go for a single ventricle palliation, and there's severe pulmonary regurgitation. So closing the PDA may not be the only modality to save the baby. You may need to surgically interrupt the main pulmonary artery and add a BT shunt or stent the ductus to maintain pulmonary circulation, and a few days later go for a stance procedure. What is stance procedure? What is stance surgery stand for? Patch closure of tricuspid valve, BT shunt, atrial septectomy, BT shunt ligation of pulmonary valve. Okay, so that's what we may need to do, but you may have to stage it. You may have to ligate the MPA and add a BT shunt, and after a few days exclude the RB. Okay. So let's move on quickly. And this is the list of the surgical management in neonates. Biventricular repair. When do you do a biventricular repair? When the RV function is good, not Craig approach, which is basically a complete anatomical repair of Ebsteins anomaly. Stance approach is RV exclusion, where you oversaw the tricuspid valve, sometimes with a perforation in it to decompress the right ventricle, and there are modification of the same. Sano approaches where you do ventricular plication, and cone operation. What is cone operation? cone operation is what is preferred of late for Ebstein's anomaly. Yeah, delamination of tricuspid valve and creating a cone-shaped tricuspid valve leaflets to enhance coaptation. So Da Silva's cone operation has a good outcome in patients with Ebstein's anomaly of late. So it's more preferred operation of late. Cardiac transplantation only when all else has failed. Okay, so when would you refer a patient with Ebstein's anomaly to the geneticist? Somebody had given an answer earlier. What association with Ebstein's would make you send the patient to for genetic counseling? What association with Ebstein's anomaly would make you send the patient to the for genetic counseling? What association with Ebstein's? Okay, left ventricular non-compaction. Okay, because there is an embryological similarity between the way LVNC develops and Ebstein's. There are some papers which say that arrest in directional growth during ventricular formation may be a common pathology for Ebstein's as well as LV non-compaction. So when you see a child with Ebstein's anomaly, have a careful look at the left ventricle to make sure or rule out non-compaction. If it is associated, then this may be an familial Ebstein's or inherited form of Ebstein's anomaly. Now, this is a child with a milder form of Ebstein's anomaly. What is the pathophysiology? How does Ebstein's anomaly of the tricuspid valve come about? What is the underlying pathophysiology that makes the tricuspid valve Ebsteinoid? Failure of delamination of the tricuspid valve tissue, correct. Sudipta Bhattacharya has answered that correctly. So incomplete or total failure of delamination of the tricuspid valve leaflets from the RV. As you can see in this cartoon, the picture on the left of the screen is a normal one where there is complete delamination of the tricuspid valve from the free wall, and when that is failed in stages, then you can have varying spectrum of Ebstein's anomaly. Okay, so the same patient whose echo you had seen 2 slides ago, the one with the milder form of Ebstein's anomaly, presented with this ECG. Identify the location of the accessory pathway in this. What feature, what parameter would you look at to identify accessory pathway location? Yeah, right-sided posterior-septal. Sudipta Bhattacharya is correct. How do you say it's right posterior-septal? On what basis do you say that? Yeah, V1 negative, transition V2 to 3 AVF is negative, brilliant. So that is a right posteroseptal accessory pathway. This is the same patient who presented with this ECG on another occasion. What is the accessory pathway location in this ECG of the same patient? V1 is negative. Right free wall, Sudipta Bhattacharya. See, when you have a QRS duration more than 120 milliseconds, it would typically indicate accessory pathway in the free wall. So what does this tell you? The same patient with two different accessory pathways tells you that there is a small proportion of children with Ebstein's anomaly who have multiple pathways. And as pediatric cardiologists, you need to be aware of the algorithm to localize accessory pathways in pre-excitation syndromes. This is an ECG from a patient with Ebstein's anomaly. List the ECG abnormalities that you can see in Ebstein's anomaly. Interfluorous complex, Himalayan P wave, okay, so the P wave morphology could be tall and peaked because of the atrialization. Right bundle branch block. This could be complete or incomplete, and this could be because of fibrosis of the intrahisian part of the bundle or compression on the AV node. Small R basin leads V1 and V2, and bizarre morphologies of the terminal QRS pattern, fractionation, first degree AV block because of a huge right atrium. Complete heart block is rare, but first degree AV block happens in up to 40%. And supraventricular tachycardias, pre-excitation and supraventricular tachycardias. Now the supraventricular what is the mechanism for the pre-excitation in Ebstein's anomaly? Yeah, WPW syndrome accessory pathway. How does the accessory pathway come into being in a Ebstein's pathology? What allows an accessory pathway to form in Ebstein's anomaly? Okay, it's a septal displacement. It's a downward displacement of the septal leaflet, which causes a disconnect between the AV groove, AV ring, and the central fibrous body. So normally the atrioventricular ring causes a complete electrical disconnect between the atrial and the ventricular tissue. In this case, the downstream displacement of the septal leaflet causes an area where there is a disconnect between the atrioventricular groove and AV ring and the central fibrous body. So you have muscular tracts passing through, and most of these muscular tracts are around the area of the tricuspid valve in Ebsteins anomaly. About 40 to 50% of these accessory pathways happen in the left free wall, 25 to 30% in the septal region, and they could be anterior septal, mid septal, or posterior septal. So 24-year-old with Ebstein's anomaly, what are the indications for surgical intervention? Yeah, NYHA class 3 or 4 cyanosis, CTR, more than 65% paradoxical embolism. Yeah, progressive cardiomegaly, resting cyanosis, severe tricuspid regurgitation, TIA or stroke. How would you classify? Carpentier. What surgical options are available? Okay, and Carpentier, cone repair, Danielson, and cone repair, like I said, is seem to be the most preferred with a good outcome. When would you opt for a 1.5 ventricle repair? You have sent the patient to surgery. The surgeon is going to do and is performing the repair, and he suddenly decides to do a 1.5 ventricle repair. On what basis would he do that? No, as you can see, this is I'm talking about this patient whose echo you are seeing here. Functional RV being small is this would go for a biventricular repair, but right to left shunt across PFO. Well, yeah, when the RA pressure exceeds LA pressure, then the surgeon would be inclined to add a cavopulmonary anastomosis to offload the repaired tricuspid valve. Okay, you're all well aware with this, so we will skip this one. The Silame S4, grade 1 and grade 4 having a very high mortality, and Carpentier classification. Okay, case scenario 4, a 24-year-old female patient with Ebstein's anomaly, resting saturation is 96%. This is her X-ray. Echo shows a Carpentier type A, mild TR, 6 millimeter secondum ASD, and there is no RV or flow tract obstruction. How would you manage? She presents with PSVT, at which time the Ebsteins anomaly is diagnosed. How will you manage this patient? 24-year-old female patient, resting saturation is 96%. What more tests would you do to help you with your line of management? This is her X-ray. EP study for PSVT, okay. EP and RF ablation. What else? Would that be the end all? Would you do any other tests to find out whether to address any other associations of the condition? Exercise test, brilliant. Mahendra Singh has suggested exercise test. Why would you want to do that? Say exercise test and she desaturates to 80%. What would be your line of management then? Operate? That's a bit of an overkill for a chest X-ray for a heart looking like this. She has a 6 millimeter secondum ASD, mild tricuspid regurgitation, and when you exercise her, she desaturates to 85. So yes, you could do a test balloon occlusion of ASD, provided the tricuspid regurgitation is really mild, and take an RA pressure and then close the ASD to prevent paradoxical embolus at the time of pregnancy. So this is what we have covered. Is planning a pregnancy in the near future? How will you manage? You would take up RA pressure after test occlusion of the atrial septal defect, and if that is still okay and the TR is really mild, you go ahead and close the ASD and manage the patient. Okay, so what are the indications for MRI in evaluation of Ebsteins anomaly? Adult patients with poor echo window and for RV volumes, yeah. Okay, so this is an MRI of a patient who presented with severe TR. What is the diagnosis? What is the diagnosis in this patient who presented with a very dilated right ventricle, severe TR? And to give you a clue, this is not Ebstein's anomaly. Let's go to the next slide of the same patient. Good. Sudipta Bhattacharya has correctly pointed out Wolff's anomaly. Well, interestingly, this is not a complete form of Wolff's anomaly. Here there was patchy absence of myocardium and replaced by fatty layers. So this is not a complete ooze anomaly. This is what we would call a partial ooze anomaly, which is again an entity which you need to be aware of, with a presentation similar to ooze and bad prognosis. So that brings us to the end of this quiz session on Ebstein's anomaly. These are some references which are pretty good and maybe you should go through. Especially there is one good reference on accessory pathway localization by QRS polarity in children with Wolff-Parkinson-White syndrome. You can have a look at that. And outcomes and predictors of perinatal mortality in fetuses with Ebstein's anomaly. This is a good paper again, a recent one in Circulation. So I hope that was useful, and all the best to you.